So first, let's start with what is ApoB. Well, ApoB is one of the apolipoproteins, and we have to recall that cholesterol is an oil, it's a fatty substance, and blood, of course, is water-based. So cholesterol does not float around in the body freely as it travels through the bloodstream. It's in fact packaged in these lipoprotein particles, and the particles themselves are actually made up of different constituents. As you can see here, the core of these lipoprotein particles has the cholesterol ester as well as triglycerides within those particles in variable proportions depending on which type of lipoprotein we're talking about. But the coat of the particles is composed of a phospholipid monolayer that has embedded apolipoproteins as well as enzymes. Again, those differ based on the type of lipoprotein particle that we're talking about. And I've highlighted here with the purple circles, those apolipoprotein B proteins that specifically define the atherogenic lipoprotein particles. In this case of chylomicrons, the ApoB is ApoB 48, and in the case of VLDL, intermediate density lipoproteins and low density lipoproteins, as well as Lp(a) particles, that is ApoB 100. And I'm going to focus most of this talk on ApoB 100. So when we talk about ApoB, the structure is such that it's a large protein that is, again, intercalated in that phospholipid monolayer of the lipoprotein particle. And there is only one ApoB 100 molecule per particle. Therefore, it directly correlates with the number of particles. So if you're measuring ApoB, it is highly, highly correlated. In fact, it should be identical to the number of atherogenic lipoprotein particles. The function of the ApoB is such that what it does is it creates the primary protein scaffolding for these atherogenic lipoprotein particles, but it is also the ligand binding target so that LDL particles can interact with the LDL receptor in the liver, but also the LDL receptor on other cells in order to allow for cholesterol transfer. So here again, you see the different types of ApoB-containing lipoproteins from chylomicrons, the very largest particles, with the constituents inside being largely triglycerides, shown in blue, and then cholesterol ester, shown in yellow. And then as the size goes down and the density increases, the density decreases, what you can see is that there's less and less triglyceride and more cholesterol ester as a proportion of the internal contents. Now, you all know we've focused most of our attention on the cholesterol content of these particles and not so much on the particles themselves as we've looked at both what creates risk and how to treat it. But I think increasingly we're going to see more and more of a focus on these ApoB particles as a whole because all of them are, as a class, creating the atherogenic risk. Now, an important way to think about ApoB-containing particles is that they are the energy delivery system for the body. These particles are circulating in order to deliver triglycerides to the tissues for energy use or energy storage. That's the main function of our lipoprotein systems, is to deliver energy to the tissues. It's not to move cholesterol around the body so much. It's not really to actually do much of anything with cholesterol, because while some cholesterol is delivered by these particles, for the most part, that cholesterol is leftover junk and garbage. It's not required very much for much constitutive activity by the body at all. So yes, there is some cholesterol that's transferred for membrane repair. There's some cholesterol needed for hormone biosynthesis, but for the most part, the cholesterol that is circulating in these particles is just junk. And so we don't need it, and it only causes problems when we have too much of it floating around. And you can see that then in this nice synthesis of the different exogenous and endogenous pathways of cholesterol transport around the body. The exogenous pathway is related to what we eat in our diet and what gets ingested through our intestines. So after we eat a meal that has fat in it, triglycerides and cholesterol are absorbed through the intestine, and they're packaged in chylomicrons, which again have ApoB 48. Those chylomicrons circulate around the body and they drop off triglycerides and get smaller and smaller as they do so in order to provide provide energy to muscle tissue and also provide those triglycerides to fat tissue so that it can be stored for later. So this is what happens immediately after a meal when we have a relatively high energy situation. But of course, we're not eating all the time, or at least most of us are not eating all the time. So we need the endogenous pathway as well. And this is where cholesterol and triglycerides are synthesized and or repackaged by the liver and sent back out to the body in between meal times so that there's still a source of energy floating around. Those VLDL particles are what the liver produces with ApoB100 now on the particles. And again, they are circulating in order to drop off triglycerides at muscle tissue or at fatty tissue, and they get smaller and smaller as time goes on and have less and less triglyceride content and proportionally more cholesterol content. Okay, so what is happening with these particles then as they float around but still have cholesterol content in them? Well, you all know, as cardiologists, that they are the central molecular determinants of atherogenic risk. So this is a wonderful article now, 15 years or so old, from Ira Tabis in Circulation that really lays out for you the dominant theory about atherogenesis, and it's called the response to retention hypothesis. So in the top left here, what you see is a normal, young, healthy artery, and those little yellow dots are actually LDL particles that are floating around in the bloodstream. Now, those LDL particles can transit across the endothelium into the subendothelial space, and they do so in direct proportion to the concentration of LDL particles, or ApoB-containing particles, in the bloodstream. So the more of those particles that you have, the more of them will get under the endothelium. And they can actually then transit back out and go back into the blood pool quite freely, and they go back and forth. Unless, as is shown in the upper right of this panel, unless they get modified. So when an ApoB-containing particle is in the subendothelial space and something happens like it gets oxidized, it is then stuck. It cannot get back out of that space, and it will stay there and elicit an immune or inflammatory response so that the body recognizes this as a foreign problem and it tries to clean it up. So those retained lipoprotein particles are actually what initiate the vast majority of atherogenesis. As time goes on, and particularly in the setting of more and more risk factors, we do see that there is increasing amounts of retained lipoprotein particles, and the body responds more and more, creating fatty macrophages, macrophage foam cells, and ultimately full-blown plaque, which can lead, of course, to plaque rupture and other problems. This is what it looks like histopathologically. And you see again in the middle column, you see lipid deposition over time in response to ApoB-containing particles, and in the right column, later on, the development of macrophages and foam cells. Okay, so what about the levels of ApoB and the risks related to cardiovascular disease? Well, we know that ApoB and non-HDL cholesterol are both positively associated with coronary heart disease risk, and in general, they are similarly associated with coronary heart disease risk. You see that in the top here. And in fact, in other studies from other large pooling cohort projects, you can see that ApoB tends to be associated with higher risk in some cases than is non-HDL cholesterol, but both of them, of course, are associated with higher risk. Now, when we analyze that risk comparatively, most of the time we use things like the ROC curve to compare C statistics, or the area under the curve, to decide which is doing a better job at discriminating those at risk from those not at risk. In general, most of these ROC analyses show us that whether we use total cholesterol or total HDL or non-HDL, it's pretty similar in terms of predictive ability compared to things like ApoB. That's at the population level. Where things get interesting is actually at the individual level, because at any given level of LDL cholesterol, some people will have a lot of particles carrying that LDL cholesterol, and some people will only have a few particles carrying that LDL cholesterol. And so there are different types of people in the world who have the small, dense, numerous LDL particles or the big, fluffy, less numerous particles. And this is where we see the difference. Notice that with ApoB on the x-axis and non-HDL on the y-axis, there's quite a range of non-HDL for any given level of ApoB, and there's quite a range of ApoB for any given level of non-HDL cholesterol. The risk in these discordant individuals tends to follow the ApoB rather than the non-HDL cholesterol. And we saw this also in the Cardiovascular study, where in young adults in the lower right quadrant, about 8% had a high ApoB level compared to their, relatively compared to their LDL cholesterol. And those individuals, as shown here, had higher risk of coronary artery calcium in young adulthood. So the risk, again, tends to follow the ApoB. This was also shown in the Framingham study, where, again, higher ApoB for any given level of LDL or non-HDL was associated with higher risk for events. So these are discordant because, again, that I think that at the population level, you kind of get swamping out of the effects of ApoB discordance. But when you're thinking about individualized patients, this is where I think ApoB measurement can be particularly useful and find those individuals who have more ApoB for any given level of LDL or non-HDL cholesterol. In fact, this also extends to patients who are already treated on statins, and for any given level of LDL, if the ApoB is higher, you're also going to see a higher risk for both mortality and for cardiovascular events. So what does the future look like for ApoB? Well, I think there are pros and cons. The pros are that this is a standardized assay that is better measured than the Friedwald calculated LDL cholesterol. It's causal, obviously better for risk assessment in individuals for primary and secondary prevention, especially if you think about this in a discordance manner. But at the population level, I think we do need to be thinking about both non-HDL and ApoB in replacing LDL cholesterol. So for take-home points, I would say ApoB-containing lipoproteins are a central causal factor in atherogenesis. They help quantify the atherogenic contribution of particles. They're carrying all of the types of things that we're concerned about, including triglycerides, non-HDL, and LDL. And at the population level, as I said, this is helpful, but at the individual level, I think it's particularly helpful. And I suspect that the guidelines are going to be moving in this direction, so it will behoove all of us to get more familiar with the measurement of ApoB and how it can help us with understanding risk in our patients. So thank you very much for your attention. I appreciate the time.